You can induce long-standing ED on TRT if you're listening to the people that say don't manage estrogen and that DHT doesn't matter. Yeah, I know this sounds crazy, but yes, erections can fail on TRT. Actually happens all the time. I mean, frankly, that's why we're in business, because I've made it my specialty to resolve erectile and libido issues on TRT. Obviously, people would be confused by that because going on testosterone, I think just people have this somewhat backwards. People predominantly think that testosterone induces sexual function, sexual behavior in men. And the truth is, it actually doesn't. Sure, there's some nitric oxide optimization. Sure, there's androgen receptor binding in the brain, but that's largely a conversion to DHT via 5-alpha reductase. And sure, there's plenty of studies on testosterone restoring erection quality in people that had ED. But the reason that it does that is via its primary metabolite, which is DHT. However, as I've described before here, just injecting a bunch of testosterone or applying testosterone via cream and having a lot of DHT doesn't necessitate erections. You might still have ED with sky-high DHT. In some cases, due to the ester, longer esters like Cypionate or Enanthate, the conversion of the metabolites is a little skewed ratio-wise. There's too much estradiol and not enough DHT. So there's actually hosts of reasons that erections fail on TRT, which again, I know sounds absolutely crazy, but it happens. And if you don't meticulously manage your protocol, you're gonna be a victim of this. And if you're in this state now, listen up, this video is for you. Let's talk about how to fix it and why they fail on TRT. Before we get started, look, Cortex Labs, which is my company, is a TRT guidance and sexual dysfunction resolution company. Got a range of different products ranging from the source list. Listen, if you need any anabolic you can think of, a vetted list of hormone and anabolic and androgenic agents, just get source list. It is livecortex.com. You can download it immediately. It's also down in the description of this video. Courses, Mastering Testosterone Cream. If you want to fix libido and erection problems on cream, or you want to move from Cypionate to cream and get stellar sexual function, I create the instructional video course to do that. You can get it down below. And lastly, I'm a coach on TRT, specifically in resolving sexual dysfunction. We've got a one-off single session consult, a 3-month intensive, a 6-month advanced TRT sexual function restoration coaching program, and host of other options you can book in under a minute at livecortex.com. So the first and primary reason erections fail on a TRT for people is just estrogen. Listen, estrogen is a predominantly female hormone. We need a degree of it for brain, joint, otherwise health. Male estrogen usually sits at 20 picograms per milliliter, 25 picograms per milliliter. A natural male, like a male that's not on exogenous androgens, and that's for a reason. That is where we are supposed to be. Now, there's a lot of information out there on the web that sounds logical and sounds like it makes sense, but is actually bullshit. One of them being, well, if your testosterone levels are rising disproportionately, well, then disproportionately estrogen is going to rise as well. Test converts to estrogen. If your body's got 1,500 to 2,000 nanograms per deciliter of testosterone, total test, that is in your blood, and over range free testosterone, well, where's it going to go? It's got two metabolites, DHT and estradiol. So more is going to convert to estradiol, and that's okay. However, that's not true. It's not okay to have more estradiol. Just because your body does that naturally does not mean it is good. It means your body has too much testosterone and it's just doing what it does, which is convert to estrogen. This is the paper I will continue to come back to. It is titled The Association Between Elevated Serum Estradiol Levels and Clinically Significant ED in Men Presenting for Andrological Evaluation. And regarding erection quality, they actually identified in this study a sharp downward inflection point at serum E2 levels when they go slightly above 32 picograms per milliliter, where erectile dysfunction is a lot more likely. Basically, the cutoff is 32. Now, some guys can tolerate 40, 45. That's rare. Rarely do you see a guy at 55, 60. Estradiol and sexual function is good. They usually have ED. But again, you need to be in 20 to 35 or so picograms per milliliter on TRT, with androgens at 600, total testosterone 700, 1,000 if you can manage it with an AI or DHT derivative, and then you're going to have great erectile function. And in this thread, there's actually a guy that sums it up perfectly for everybody to just stop wasting time and take the advice of. This thread is titled Libido and Erections, What Total T and E2 Levels Give You the Best Sexual Function. I want to make this clear. It has nothing to do with total T or free T. Okay, people that tell you got to get your total T to some level to get erectile quality, wherever, it is absolutely positively the wrong advice. It's largely irrelevant. The only degree to which it's relevant is how much is converting to DHT. This is the comment to look at. I try to keep my E2 near my SHBG, which I don't always suggest, because if SHBG is at 40, you don't want to have your E2 at 40. But he says, which is low 20s. That makes sense. And I'm always in a good zone. Anything above 35 for myself and can definitely lose erections. I want to make this clear. This is the case for most guys on TRT. You start pushing 35, 37, 40, you're going to start losing erections for most people. Now, this is an individual who can tolerate AI, so he's got 0.125 to 0.25 milligrams of Arimidex once a week, keeps him in that E2 zone of 20s, the 20s, the low 20s, and where sexual function's good. Now, of course, you do not want to take that too far down via manipulating your dose or taking an AI, because you got cases like this. Total T 800, but E2 is 8. SHBG is 85. Don't know why that is. But E2 at 8, no libido at all. You're not going to have libido with estradiol at 8. It needs to be around 20 to 30. I think folks need to ask this question when it comes to estradiol and whether or not they're going to believe that, elevated estradiol is what causes ED on TRT, besides, not having enough DHT, which we're going to get to next. Why is it the case that folks go on cycle and lose erections? On cycle, 350, 500, 750 a gram of test a week, you obviously have enough DHT. Even if you're an underconverter, you're going to be supraphysiologic in dihydrotestosterone levels. So why do people go on cycles if this logic of, well, we need estradiol, it converts, proportionately based on how much test you have, and that's fine. Why do people go on cycles and have ED? Testosterone cycle and erectile dysfunction issues. Hi guys, 40-year-old guy here, fit, currently started taking my first testosterone Enanthate cycle, 125 milligrams every other day for the last 4 weeks. I'm starting to see some aesthetical results, but also experiencing some ED issues. Unable to get it up and keep it up, which is very uncommon. I consulted my doctor who thought it could be age-related. Like, this is where people are just, excuse my bluntness, just being fucking idiots. It's not age-related, dude. It's E2. One guy in the comment section lays it out. If you're not taking an aromatase inhibitor, then high estrogen is the cause of your ED. It's really that simple, guys. Now, let's switch to DHT. The other reason that you've got ED on TRT is you don't have enough DHT. Now, this can happen for a variety of reasons, and usually it happens on longer esters like Cypionate or Enanthate when you're converting a lot to estradiol, which they typically tend to do, and you don't end up having enough DHT. And that's usually when people go down to ultra-low doses like 110 or 100 milligrams a week or 120, and the E2 falls at 25 where it's supposed to be, but then DHT is kind of low normal. We've been through all this before, but, just to sort of hammer it home, this is a paper titled The Effects of Oral Finasteride, which is a DHT blocker, on erectile function in a rat model, in which via blocking DHT, they found that in 4 weeks of doing that, it reduced the weight of the corpus cavernosum, the spongy tissue of the penis, where a lot of test gets converted to DHT via 5-alpha reductase enzymes and is extremely necessary for the health of the endothelium and nitric oxide signaling. After 4 weeks, it didn't affect the erectile response in response to electrical nerve stimulation, but after 6 weeks, 8 weeks, it almost definitely will. But the weight of the penis reduced from blocking DHT. How much more clear can I make this? This paper as well, dihydrotestosterone being the active androgen in the maintenance of nitric oxide mediated penile erection in the rat. The castrated rats, they gave them testosterone. Testosterone did not resolve their erectile difficulties. They gave them DHT. Erection problems resolved. Persistent erectile dysfunction after discontinuation of 5-alpha reductase inhibitor therapy in rats, depending on the duration of treatment. They found that the administration of Dutasteride in this case, for those that say Dutasteride is safe somehow, even though it still blocks 5-alpha reductase isoenzymes, for more than 8 weeks in rats could result in irreversible ED, even after discontinuation of medication. Yeah, this is otherwise known as post-finasteride syndrome in people, real men, that this happens to all of the time, that come to me and have been coming to me for years. This whole irreversible thing is actually not true. It is reversible, but you need loads of DHT and to keep estrogen in a very tight band for a consistent period of time for erectile function to come back. But it proves when you block DHT, tests can only convert to two things: estradiol or dihydrotestosterone. When you block its conversion to DHT, guess where it's going to go disproportionately? To estrogen. These cases are exactly what I'm talking about. They prove it. overage of aromatization, more estradiol than you need to, and a lack of DHT causes erectile dysfunction. You can induce long-standing ED on TRT if you're listening to the people that say don't manage estrogen and that DHT doesn't matter, but especially the don't manage estrogen part. You are inducing, you're manufacturing a post-finasteride syndrome-like state. I need you guys to understand that. I need everybody to fucking understand that. So let's talk about what to do with it. Listen, I've been over this a lot, but I'll break it down in just sort of a summary depending on the ester and depending on what you're doing on TRT. Look, if you're on testosterone, Cypionate, or test Enanthate and you like it, fine. You can totally stay with it. I mean, those esters do work. They're just harder because they convert a lot to estradiol. And typically, like the higher doses that make you feel good and feel stable end up making you over aromatize. So too much estrogen, erectile difficulties, libido difficulties, hard to dial in. If you're going to run the higher doses of Cypionate or Enanthate, you have to use an AI. You have to use something that lowers estrogen to the point where it's in the 20 to 30 window. And then as long as you don't have any side effects like joint pain or libido loss in the brain via uneven distribution of estrogen at the tissues, which sometimes happens with aromatase inhibitors, then you're fine and dialed in. Again, a lot of folks try to go down to 120, 115, 100 milligrams of Cypionate. They get the estrogen in range, but DHT is low normal. It's not enough DHT for you to have stellar erections. You might be okay for penetrative sex. You take 5 milligrams Cialis, you're okay. But even then it's not optimal. And with lower end DHT, you usually have a lot less libido. In those cases, a variety of things can be done to resolve erectile issues. Say you have to go down to 110 milligrams of Cypionate per week to get estrogen at 25, but DHT is still low. Then just add 25 milligrams of Proviron a day. You add Proviron, you get the androgen receptor binding both in the brain and the penile tissue that mimics DHT. So your body actually feels like you're having a lot more DHT. You block the sex hormone binding globulin, so you free up more actual free DHT. And then, as the forum state, as a lot of my coaching clients have experience with, and most folks out there that try Proviron, you get restoration of erections when you try Proviron. Why? Well, Proviron actually does two of the things that we want. Increases the DHT-like effect and blocks estrogen to an extent, albeit a minor extent. If you run 50 to 75 of Proviron a day, you get a lot more of an estrogen blocking effect, which some people have to do to resolve erection issues on TRT. But in those states where you're having to lower your long ester dose, like to the point where you're really not even anabolic and you have less energy, the best thing to do is just to switch to transscrotal testosterone cream, and particularly the 100 milligram per milliliter stuff. Then, because when it peaks very swiftly within the first 5 to 6 hours in total T, and then DHT shortly thereafter, it actually stays physiologic for quite some time, basically the rest of the day. So you keep your anabolism and your energy and you feel great, but also you get loads of DHT via all these 5-alpha reductase enzymes that exist in the testicles. It's like 5 to 8x more than any other area in your skin. And the testicles are the most highly absorbable site on the male body for transdermal testosterone. Cream revives erections. Why does it do that? Well, if you're converting more to DHT, number one, you have more DHT, so that's why. But number two, as a byproduct, naturally, you're going to have less estradiol. Testosterone can only convert to two things: estradiol, DHT. If it's disproportionately converting to DHT, you're going to have less estradiol. Cream is, in fact, the anti-post-finasteride syndrome, by the way. It is the anti-finasteride. Gives you more DHT and less estradiol. I have seen these weird cases where guys have struggled to dial in erection specifically, but libido also kind of comes along with that on TRT. But they've never had any hair loss on TRT. So the whole time they've been on TRT, they've tried various doses. They've gone down to lower doses. They've gone to somewhat higher doses. But erections have always been a problem. They've effectively had ED on TRT. Then though, they got their DHT high enough to induce a healthy erectile response while getting estrogen within their range, again, 20 to 35 picograms per milliliter. They got their erections back, but only then when also simultaneously they started having hair loss. What does that tell you? All the while, you weren't getting enough DHT and estrogen was too high. That's a crappy place to be, obviously. It's like you're male organ or your hair. It's your D or your hair. I mean, I think most of us would choose the D, but some people that are in a bad position genetically have to face that dilemma, and it's unfortunate. DHT itself, transdermal DHT, can't really tell you, man, because it's innumerable at this point, meaning I can't actually calculate it. How many people that I've helped get erections back from just using transdermal DHT? Of course, we had to get estrogen in range, but in some cases, people wanted to stay on Cypionate. They got their estrogen at 25. They like the Cypionate. They like its stability, the anabolism, and how they feel, but they weren't making enough DHT. So we had to drop 1 milligram of transdermal DHT oil on the scrotum every day or every other day, every third day. It was like the biggest frequency gap. And then the erections came back. Bottom line is this, everybody. Testosterone is not what drives your erections. And the notion that it does comes from people that are approaching the topic with a lot less nuance. That would be people that aren't specialists in it, right? That don't think about it every day and work with folks in this capacity every day and haven't done the heavy research thinking about it from a really granular perspective. Testosterone induces anabolism, man. It induces protein synthesis, but also it then converts to DHT and estradiol, and that's really where your sexual function lies. DHT needs to be high, estradiol needs to be in range. You've got conversion of DHT in the hypothalamus. This has been shown where there's a boatload of 5-alpha reductase enzymes in rats and dogs in the hypothalamus of the brain. This is your sexual center here, boys. You get those two hormones where they need to be for your body. You fix erectile problems on TRT. You get your estrogen down when it's up and you have ED. As long as DHT is high, you fix your problems with erectile function on TRT. You're down there in the 20s in estradiol and things should be fine, but then you go look at your blood and your DHT is kind of lukewarm in the low middle range. You take a little DHT, or you switch to cream, you get the DHT up, the estrogen still stays in range. Erection problem resolve on TRT. Yes, it is the case, unfortunately, that, people can have ED on testosterone. It's not necessarily going to fix it, and especially if you're listening to some of the BS that's out there on the web, the non-nuanced BS. Heavy dogma about these ideas that estrogen being cardioprotective and joint and brain protective, so therefore you need to not manage it. And like if you're loading yourself with testosterone, well, obviously you're going to convert more to estradiol, and that's natural. That's what's supposed to happen. Well, yes, it is supposed to happen. That's what your body's going to do with a lot of tests. It doesn't mean it's good. Show me where it means it's good. There is an error in that argument, and I'm calling it out. Boys, get the DHT up, get the E2 down, thank me later, resolve erection issues on TRT. Point blank. There is no discussion. Hope that makes sense. Look, if you don't want to go at this alone, book me for coaching. I mean, that's one of the primary things that I do. In fact, these days, I haven't had a coaching client come through that it wasn't related to erectile issues or libido issues on TRT. Been doing this for more than a half decade. We'll get the situation resolved. It is about the micro tuning when it comes down to protocol adjustment that ultimately gets these metabolites in the sex-friendly zone, and not everyone knows how to do that. I've made a specialty of doing it, a career of doing it. You can book me in under a minute, livecortex.com. There is a sexual function blueprint consult, a single session call with me where I will generate 3 to 5 clear action routes in an entire protocol document on the web for you to go right off into the sunset and dial in. If you need more intensive work, go for the 3-month TRT sexual function restoration intensive. This is where you've tried a lot of things in the past, and we're going to need time. We need to adjust the protocols. We need to look at where estrogen's going, where DHT is. For folks with long-standing sexual dysfunction that is unresponsive to various protocols over many months or years, go with a 6-month program. This is an advanced TRT sexual function restoration coaching program where you're working directly with me. You can book any of these in under a minute, livecortex.com. The website will provide a pop-up to give you 20% off. Please use it. If you need to get compounds that you want to go out this alone with, DHT itself, namely Proviron, erectogenic agents, just by source list. I created a vetted list as you see here on the screen. It's down in the description of this video. It's been a help to a lot of people, thousands, so please go get it. If you're on test cream and need to dial in libido and erections, just get this course. It is the official instructional course after years of experience with this to dial in sexual function on test cream. It's a downloadable video course and you can get it instantly at livecortex.com. Hope you guys are having a great week. It's been an absolute pleasure hanging out with you. Much more content to come soon. Like the video. Makes a huge difference. Honestly, for the channel, let's continue growing. If you're new and you're not sub to the channel, love to have you on board. We're going to be breaking this down forever in the time continuing. We got a lot of content so far, so please go check it out. I'd love to have you on board. Otherwise, kick ass, rock on, enjoy the rest of your day, and I'll talk to you boys in the next one.